All right, everybody, let's take a look now at the relationship between the dentist and the technician. And, one of the things that we absolutely understand now is that the ability to communicate in the digital world so surpasses anything that we could do in the analog world. So when we think about Brian's case and these principles of occlusion we just went through and aesthetics and all those things, one of the greatest challenges is if you decide to be scanning and not have software or not have a printer, you can still do all this at extremely high level, but it is the dentist's responsibility to still quarterback this thing. You still have to make decisions about what your goals are, and that means if you're going to have a lab mount the case, if you're going to have the lab be making you provisionals or shell temps or an implant case, you have to communicate. And what's so great about this is that if you work with a lab who's using this type of software, as Lee will show you, you can go on Zoom or TeamViewer and look at what they're doing, and it's like you're sitting right next to one another. And we've all experienced in the analog world, often we wouldn't look at the wax up till about 30 seconds before we were starting to prep, and that's not the best time. So with that, excited to have you listen to Lee for about an hour. He's one of the best in the world at this. Certainly my partner in crime with most of my cases. So Lee, have at it.
Okay, thank you, John. And again, I just want to say something real quick. As I was listening to John, I could literally just close my eyes, and it was like being in a Pete Dawson seminar from 15, 20 years ago. So just wanted to say phenomenal job. It was like being back in the audience again. And that's the point of everything we're doing. I mean, John and I both came from that background. So I've never done anything different. I mean, I went to Pete's courses early in my 20s and have always done things this way. So whether it was metal ceramics and green Maves wax way back in the day, or whether it was Empress and then more tooth colored waxes, and then going into other all ceramics and zirconia, and then going into digital, we still do the same thing. We don't do anything different. We just do it in a different format. And that's what I want to talk about today is how we do that and why it's better. So a lot of things in digital, I always like to look at, is it different or is it better? Different is okay too. Better is obviously even better because it's quicker, more concise, better communication. And I've said since day one, when I started digital, and we were literally one of the first digital labs on this planet working back with CEREC and developing CEREC in lab, one of the things we saw real quick is communication. There's CAD CAM where we make things. Those are the machines, those are the software. But what John was talking about earlier is our ability to communicate has never, ever been like this. So whether it's John and I letting him look at a diagnostic design, or whether it's John and I and the periodontist trying to figure out how to even up gingival architecture, or whether it's John and I and a surgeon working to place implants for the optimal goal of patient health, but also so all three of us understand where the other one's coming from so we can do the best plan possible. So it's always been about communication. So we've never had communication like this before. So it just enhances the partnership we have today and the things we can do. So things we work with every day now, artificial intelligence. So we do a lot of surgery where one of my technicians, Matt Stone, used to spend hours taking a CT scan and converting it into a very clean STL scan. We use artificial intelligence software that takes about 5 minutes now. We just send it into the software. It converts it, separates all the bones, all the roots, everything, and gives it right back to us. So artificial intelligence has helped us a lot. And it's going to get bigger and bigger and bigger and bigger until I will eventually not have a job in design because the computers will do everything. So next is the one that's really taken over, and the one that took over very quickly, this robotic manufacturing. So you can call it a mill, you can call it a printer, or you can call it a robot, because essentially that's what it is. It does things for us. It makes things. It makes dentures, it makes crowns, it makes guides, it makes anything that we do in our laboratory. In fact, 60% of what we do in our laboratory today is printed somehow or another, whether it's resins, whether it's PMMA. We're printing metals now for our guides and some of the more complex things we do in maxillofacial, but we do a lot of printing. And then the other thing would be milling. Milling was really the first to come in way back in the CEREC days when we were milling Empress. John and I were both CEREC way back in the beginning, and we would design a crown and then mill that crown. So milling has been around for a long, long time. It's only gotten better over the years. We run 3 full-time mills that will run literally all weekend, and we're fixing to add another one in just for milling metal, chrome, cobalt, and titanium for abutments and bars, and again, some of the maxillofacial stuff we do. So robot manufacturing is a big one. Printing, when we look at printing, printing is really where the emphasis is on today, especially for dentists, because most laboratories have a printer by now. Maybe not all, but most do. So the market is kind of done, kind of saturated. I've got 7 of them, and most laboratories at least have one. But you're the market. So in North America, there are about 7 or 8,000 laboratories. We're kind of done. That's the market. But dentists, there's 225,000 of you. So you are the market for printing now. All the printing companies are basically focusing on dentists. And then augmented reality, some of the surgical softwares we're working with now, we can actually put on augmented reality glasses and work that way on our computer and kind of see things 3D. It's kind of cool. There's going to be a lot of new teaching coming in with augmented reality. So we're going to see a lot more of that, and also patient education. Started a little bit, but patient education is going to be a big one with augmented reality too. So now that we're working to all become digital, laboratory technicians and dentists, we are creating a digital team. And that digital team, the roles are changing in what we do. So we're redefining those roles daily on what a laboratory does and what a dentist does. And we started this again many, many years ago with CEREC, when CEREC gave dentists the opportunity to become lab technicians. Now, I was the technician who was not scared of CEREC, didn't run away, didn't say bad things. I ran to them and said, "This is cool. Can we do a lab system?" And then we developed the CEREC in-lab system. And we've since gone through different things. I actually was hired away from CEREC to go to E4D when they were a startup company to help them launch, and then eventually was hired away from them to take one of the largest laboratory groups in the US completely digital, which was about 20 labs at the time. But when we look at what I do and what technicians do, I'm a crown and bridge technician. That's the way I was trained. Crown and bridge is making crowns, single teeth on preps. That's what we do. The other technician would be the removable technician. So the removable technician is trained to do dentures and partials. And rarely in the past did we cross over. Crown and bridge technicians, some did, but crown and bridge technicians really didn't do removable, and removable technicians really didn't do crown and bridge. So when digital dentures started forming and some of the thoughts, Ivoclar and 3Shape came to me for the denture project, which I kind of thought was odd. And I'm like, "Why do you want me? I have no idea how to do a denture." And the reason they kind of chose me is, first, I knew digital, but they wanted to choose somebody who did not know anything about dentures. So I had no preconceived notions. I had nothing in my mind of, well, this is not the way we used to do it. This is not the way you do it in the analog world. I had none of that because I don't know how to do a denture. So I learned how to do dentures in 2 days. I was no master at it by any means, but I could make a denture. I mean, wasn't perfect, but I could do a denture. So that wall went down quick. between crown and bridge and removable technicians. The other one is what we do as technicians today and what you do as dentists today. So I am a clinical technician, not a dentist. I do perio, I do ortho, I do restorative, I do diagnostics, I do removable, I do equilibrations, I do maxillofacial surgery. You know, we do some crazy things here. And that's what I do basically all day on a computer. I have phenomenal technicians who do most of the ceramic work and finishing work right now. But this is what I do. I do dentist work all day long. And most of the dentists, or a lot of the dentists now, are starting to do a lot of technical work. Again, we go back to CEREC, we go to E4D. I always like to really talk about CEREC because they're the ones that started this whole thing. And then E4D came in to give them competition, and that's where growth exploded. Because CEREC really never had competition before until E4D came in. And then you had the others kind of sneaking up behind with ExoCAD and 3Shape. But dentists are making a lot of things they use today, from crowns to splints to temporaries to dentures to occlusal guards. All kinds of things can be done with the software and the printers or the mills. And it's actually a whole lot easier than it used to. In the beginning, it was not so easy. Now software is very good and the mills are good and the printers are good. So it's a lot easier to get an outcome. So there's a lot of technical dentists out there doing a lot of technical work. And then restorative surgeons. So this is kind of the fun one because this is where our lab really specializes in is surgery. And again, I love to do surgery and learned a lot. I don't know that I have a friend who's not dental in some way. John, dental. My wife is a prosthodontist and surgeon. Dr. Lyndon Cooper, who I learned so much from, who's the dean at Virginia Commonwealth now. But everybody I know is a dentist. So I had a lot of people to help me learn the aspects of doing that. But in turn, I did tend to look at things a little bit different than restorative dentists sometimes and surgeons. So it was kind of fun to put these things together and communicate with restorative dentists and the surgeons and them communicating back with me so we could get the ultimate plan for the patient. But surgeons are really looking at things restoratively now and not just where the bone is. So what's possible? What can we do today? How can a laboratory help you? So there's a couple of things. There's different ways to do this. And John does an excellent explanation of how you can look at digital. So you can get a scanner. Well, and again, I push scanning. You don't really need a scanner to go digital. And I'm going to bite my tongue when I say that because I'd rather you buy a scanner. But we can take an impression and we can digitize it. We would rather get the data in. So everything in our laboratory is not digital. I would say we're probably up to 70% at this point, but we've still got people who send in impressions, and we're doing the best we can to try and change them all because scanning prices are coming down. But when the data comes in, let's go back to scanning. When the data comes in, we take it, we do a quality control, make sure the bite's right, because we're going to do the same things we've always done. We're going to look at the bite. Can we see the margins? Do we have enough prep room? All those things we can do. So if you've got a scanner, you can go digital. Just send your lab the data, and there's virtually nothing we can't do with that data. The other thing you can do is buy a scanner and then get some software and do some diagnostic designs and different things that you can do so you can start to learn and take a little bit more control. So you've got a scanner or you've got a scanner and software. And the third one is you've got a scanner and an output device, which is a printer or a mill or both. But you don't have to go all in and buy everything. Again, if you get a scanner, you're digital, we're working together, and we're doing fine. So what can we do that? So first, if you've got the software or I've got the software, we can mount our cases. And everything is already been put into the software on geometric and anatomical geometry. So when it comes in, there's a plane which we're going to set it at an average at 100 millimeters from the condyle. We're actually, I showed John earlier, a little earlier today, a Monson's curve we're working on to be able to do things a little bit better. But virtual articulation is very quick. So we've immediately eliminated taking an impression, pouring it in stone, trimming it up, and then going and taking the bite and potentially a face bow and putting it on our articulator. We're going to take those scans, put it in the software, put it on an average articulator mounting very, very quickly and be ready to look at it. So you can look at it in CO, CR, you can equilibrate. There's lots of things you can do incredibly quick to get, even while the patient's sitting there, to be able to communicate back to your patient. So either we can do that or you can do that. So it looks kind of like this. In the first step, we're just going to take our upper model and put it on a plane. We're going to put the centrals where the centrals go and then kind of tilt it so it gets the arch in the proper plane. We do that at the beginning because where we're putting it on that arch now and that sphere is going to place it on the articulator automatically like you see here. So there's several articulators in there depending on where you've learned. We've got Stratos, we've got Cavo, we've got Hanau. There's a lot of articulators in there, you know, based on the articulator that you use in your office. So maxillary cast using Bondwell points of 100 millimeter. Mandibular cast will appear wherever you took the bite. You don't have to do anything. Your cast can be mounted accurately, literally in minutes, and there is no wax. So now that we've got everything done, there's a couple of ways to tighten it up a little bit. We can use 3D facial scanning, which we've been doing since the beginning of facial scanning, or you can do 2D pictures. So we can actually take 3D data, the articulator, the cast, and register it to a 2D photo. And we actually get really nice results to be able to quickly diagnose a case and look at the case, and not quickly diagnose, but at least get a visual on where we're looking at cants, looking at incised ledge position, all those things. We can see those actually pretty quickly. So when we take everything into consideration, we've got a scan. So we've got the scan and we've got a bite scan. We can register and pin those scans to the CT. So we've got the CT and then we can add a face scan to it. Now what's cool, and this is really when I showed John some of these videos way back. This is when he got excited because he can you can mount it on an articulator, and I'm like, yeah. So we've got the face, we've got the teeth, we've got the articulator. We can line up the condyles actually even a little bit closer. We can add the facial scan to it, and we've got a virtual patient on our screen. I mean, right there, we've got pretty much everything we need. And we can set the articulator or use average settings to look at the articulating and see where the teeth are touching, see if there are any interferences. And then what we can do is we can actually take the articulator, stepping back 1 second. When I was learning from Dawson and we mounted our stone models on the articulator, we would pin all the posterior teeth in stone. So we could immediately take all the posterior teeth out to see where the anterior teeth touch or not, because if there were posterior interferences. Here, the teeth just go through each other. We just shut the articulator down on an arc, and when we see a mark, a lower incisor touching an upper incisor on the lingual, we stop. And then we can evaluate, do we have good contact? Do we have a little contact? Where's our first point of contact? But because the data of the upper and lower can actually pass through each other, we know immediately what we can and can't do or may need to do. And we can do that, or you can do that if you have the software. And we can also bring that in to different softwares, the intraoral scans, the CT scans, the facial scans. We can do ortho here. We can do maxillofacial. We can do implants. But taking this data, we can move the entire maxilla. And the software we use, the skin would actually move with it. So you would see not just bony changes, but soft tissue changes. So let's go to a basic one. So the first one we can do is a diagnostic design, and that's just setting teeth, and just like we did in wax. But again, we set teeth that are already formed, they're already really nicely shaped teeth. We just grab them and three-dimensionally set them where they need to go and kind of take a look. But where do we go after that? What can we do with that data? So we can make provisionals. Now, in the past, we have not, laboratories, at least my laboratory, did not like to make temporaries because there was a lot of labor. The labor involved in making a temporary restoration was basically the same as making a ceramic restoration. And unfortunately, the fees for those were almost two-thirds less. So you don't really want to be spending all your time making plastic teeth for two-thirds less of a fee. But today, with printing, and we don't mill provisionals any longer. We mill provisionals for years and years and years. And then when the new resins came out that were strong enough to be able to make provisionals, we started printing all of our provisionals. So we love to do provisionals now to help with our dentist and our patients visualize or test out function, test out aesthetics. And the cool thing, which I'll explain a little bit later, with software, if you're in the analog world and we do a diagnostic wax up with wax, and we take that, we send it to the doctor, patient looks at it, everybody looks at it. We make a matrix on it, and we can prep the teeth and then put the matrix in the mouth with a BIS-GMA resin and kind of test it out. But when you start it over, so I did an initial design, you basically kind of have to start over. And then when we go to the final restorations, we start over again. With data, we can just move the data to the next step and modify it and changes, because a lot of times we're obviously going to have changes, but I can take that original design, that digital design, and if John calls in, let's just say it was a perfect world that day, and he goes, it was perfect, the patient loved it, we made temps from it, we're good to go. So we take that design, we move it to the temps, and then if he says it's great again in the mouth, it's just like it looks on the model, patient loves it, let's go to finals. We just take that same design. We don't start over. We just move it to the next step. So we can keep accuracy and predictability as we go along. But let's talk about temporaries. There's three ways, basically ways to make a temporary. So this is one of John's case, pre-op. And we're just going to kind of focus on the anterior teeth and the technique rather than the diagnostics in the entire patient evaluation. So we're going to do a little bit of smile design, look at changing tissues, which we can change. And one of the other things we can do here also, especially when we're looking at gingival architecture, if I have a CT and an intraoral scan, and we know we need to do some type of gingival architecture changes, but is it soft tissue or is it bone, or obviously both? But we can take that data, put it in our software, measure it exactly, and make a guide if you need to do bone. We can make a guide if you need to do tissue. But what's interesting is probably 30 to 40% of the cases that come into the laboratory for us to make a guide to kind of show the periodontist what's going to need it to be done based on math is once we do all the measurements, only about 70% of the cases actually need bone reduction to get crown lengthening. It's very cool that we can measure these things exactly. So this one was a little bit more just soft tissue. So we have the teeth under. We always like to kind of keep the teeth underneath when we're doing our initial to see what we're going to have to prep off. We know immediately we're going to have to reduce the facials of those laterals, and we can actually make a model showing where the new teeth need to be and the old teeth were, so you can go, oh, well, these parts of the laterals on the mesials are sticking out. We're going to have to prep those back. before we do the actual prep of the teeth. So now we've got a digital workup design. We can print that model because there's like I said, there's lots of ways to do temporaries. So we can still do, because it's a phenomenal technique, the direct temporary in the mouth technique with a BIS GMA and a piece of putty. Even though we've got all this digital cool stuff to do today, that's still a great way to do temps, especially if they're veneers. So one of the ways is just do the design work, make a putty matrix, and then do BIS GMA temporaries. We can still scan that and put it back in and still move all that. So we've got our temps, we've got everything we need, and we can make pre-op stents. So the first way to make a temp is just make stents. The second way to make a temp is, we do this a lot now, so is shell temps. So this is where we're not prepping teeth. We're not scanning anything. We're going to make the temps before you prep the teeth, and we make shell temps. Now, the software, a little more complex, but it's very learnable. But we're going to program the software to prep the teeth. And we can tell it how much to prep the teeth. And we usually do it at a minimal 0.5 or 0.75 preparation. And the software, we're going to mark our margins, and the software just preps the teeth. And then we can do a design over the top of them. So again, minimal prep at, we'll just say 0.5. We're going to tell the computer, prep the teeth 0.5, and then we're going to design the teeth over those preps, split them together, and then make shell temporaries for you. Now, to make sure these temporaries stay in place, we're going to add either lingual palatal rests on the lower. So we've got a lingual. If you look at the lower, there's that bony area right behind the anterior teeth we can rest on. We can go back to the bony pads around the molars, or we can go to teeth if we're not prepping all the teeth on the upper. Very easy to go to the palate, and it positions very nicely so you're not rocking it around. And we're going to reline those and just place them in the mouth right before it hardens fully. We're going to take it off, take our positioners off, and then cement right back into the mouth. So these are shell temps, positioned very nicely. They're just kind of sitting there. And John's going to reline those, and he's got temporaries done very, very quickly. And then we have our approved prototypes. If there are any changes, he can scan those, and we've got a model to reposition, but I still don't have to start over. I just go get that original data and move it up into the next phase. But it keeps it very predictable. And again, coming back to everything we're talking about today is not just digital. There's a lot of courses on digital, how to do this, how to do that, how to make this, how to make that. But we want to take it back to complete comprehensive dentistry. What we've done and what you've done my whole career, and just digitize it and use the same concepts that we've always done and just digitize them. And actually, the digital format and the digital working flow actually makes it more accurate and more predictable than we've had it in the past. But nothing has changed. We're still wax, plastic, glass. The cool thing about digital, now it's easy to do some pre-diagnostics before we print up a design, which would be wax, before we go to plastic, which would be temporaries, before we go to glass, which would be the final restorations. So, final restorations, based on digital, based on the temporaries, based on walking that through. And here's our final patient. So, another way to do temporaries. So we've got do a design, do a matrix, and BIS GMA. We've got shell temporaries where we kind of do a diagnostic design and the temporaries all at once, and then make shell temporaries with intraoral positioners to get them in the right spot. Or the third way, which we're actually doing more of, is immediate temps. We call them immediate temps in the laboratory because what you're going to do, and to walk through this, we're going to do a design, which you're going to look at on the screen if you'd like. We can send you pictures. You can go on TeamViewer, like John said. So, but we're going to do a design. Excuse me. And we can even do a quick design and do BIS GMA in the mouth just to kind of see how it looks. But on the day, we're going to prep. So you're going to prep the teeth. And when you prep, as soon as they're prepped, you're just going to scan and send me the data. Just immediately, you've got the lower, you've got the upper, you've got the bite. Now, the way John does this for workflow and efficiency, once he preps the teeth without packing cord, because that's a fairly long process in and of itself. So he'll prep the teeth and immediately scan before the tissue starts going back over the margins too excessively. And then I've got that data. So now while he's still got the patient in the chair, I'm working on the temps. And I'm going to take that design, I'm going to forward it into this new file. I'm going to position it in place. And if we're all using the same software and the same registration and the same data, the temps really just kind of go into place where they're supposed to, and we can do some slight modifications. And we're going to enter our work order a little bit different to call it where we actually go to the margins. So he's going to send me really quickly this non-retracted model. And while I'm making temps, he's going through full retraction and he's ready for, I'm going to design the temporaries. I'm going to send him to his office because he has a printer. And then I'm going to call him up and say, go print. He's going to print. He's going to finish them, take them off, finish them, and they're ready to go in the mouth, exactly like a crown and bridge margin. So we call that immediate temps, and they're to the margin. It's not a shell temp. Now, there's actually two ways to do this. We can just position, and we always go to the margin, but if you're in a dental office and you're trying to do it fast, there is a less accurate way and a more accurate way. And the less accurate way is not bad. It's not like it doesn't fit. It's just not a perfect fit. So you can position the teeth over the preps. So we're not going to mark margins. We're not going to do any of that. We're just going to take the design of the teeth and position them over the preps and get them kind of modified to get to the margins. And we hit one button and the internal part of the tooth just appears and it negatively removes everything inside of the tooth to match the prep. Doesn't match the prep perfectly. The margins aren't perfect, but I'd say you're about 75% there. It's a fast way to do it. Put the teeth in, hit one button, go to the printer. What we do when the data comes into us, we make the order form a little bit different. And we've already done this once John tells us it's coming. And then we mark everything. We mark the margins. We put the correct amount of spacer on, and we've got temps that fit perfectly. So again, even when we go to this way, there's two ways for you to do it. Good, but a little less accurate, or good and really accurate. But there's so many ways to do this. And so it kind of looks, the margins aren't perfect but you get the speed very quick. And then if we do it the other way, you get just perfect crown and bridge accuracy. And then we go to the printer where we're going to set it on the printing plate virtually and put our supports on for it to print properly. And then we hit the print button and it goes into the printer. I'm not going to do a big printing thing today. Printing is actually really easy. When I started printing over 12 years ago, it was not anywhere near it is today. We had to make up so much stuff. But you're going to print, it's going to come out of the printer. You're going to clean it up with a little alcohol to remove the excess resin. And then we're going to do a little finishing, a little stain and glaze and cure, and they're ready to go into the mouth. So what else has really changed? Dentures. Like I said, in dentures, I really have no idea how to do an analog denture. I just don't know how to do it. Never learned. Maybe I know enough now to be able to do it, but it would take me hours. I mean, it would literally take me hours, where to do a digital denture is start to finish, maybe 45 minutes. And it depends on what we're doing and in arch form and all kinds of things. If you got a lot of room and a good arch form, then it's actually really, really quick. But we do all of our dentures. Now, we don't do dentures really just to do dentures. I'm not a denture lab. We don't specialize in it. We do dentures for some people to do dentures, but we really do dentures as diagnostics and treatment plan guides for implants, because we do lots and lots of implants here, a lot of all on X. So dentures are the perfect diagnostic tool to be able to do that. Now we can print, and I could talk for 6 hours on digital dentures, because we were one of the ones that were in on printing from the beginning and in on milling and all the new things that are going on today. So this is a mill denture, and basically we mill the teeth and we mill the denture base. Ivoclar does have a disc that actually has the teeth and the base in the same disc, and you can mill them all out together. There are some aesthetic challenges with some of those discs, so we tend to do them a different way. But we've got our scanned models, we've got a bite, and that's the main thing. So it all comes down to a bite. It really is about the bite. So you hear about all these people going, yeah, two appointment, 3 appointment. Yeah, we can do that. No problem. If the bite's right. If the bite is wrong, if you send me a new bite, then we basically start over. And it's not a long process, but as soon as you change the bite, we have to rescan it and basically start over. So the process would be bites off, then you're going to reline the upper and lower dentures with a soft impression technique to re-grab that tissue and get a good tissue. And then we're going to scan it in with a new bite and basically kind of start over. But let's say the bite's perfect. Bite's perfect. It's in the computer. We're scanning the upper and lower jaws, or you have, and we'll talk a little bit about that also. And then we've got the bite, we've got the upper and lower jaw. We're going to mark anatomical marks. If you look at the bottom left-hand corner, we're going to mark the boundaries of the denture. And then as soon as we do that on the upper and lower, then that's kind of like our coping. It's going to immediately go to those margins and seal it in. We're going to take out undercuts and just make sure everything's parallel for the final denture. And then we're going to put the teeth in. Now, putting the teeth in is where it really becomes fast and fun. So the denture teeth, so there's a lot of companies have their denture teeth in. I use Ivoclar, so all the Ivoclar libraries are in there. But someone digitally set up all of those teeth forms, anterior and posterior, into a perfect optimized denture occlusion. So the upper and lower molds are locked together. So wherever I tip it, wherever I go forward, backward, tip it, wherever I move it, the upper and lower teeth stay exactly together until I don't want them to. So once I get them anatomically placed and everything's good and I like it, then if I want to unlock the teeth and make the centrals longer, twist the laterals, do something to the cuspids, make the lowers crooked a little bit, I can unlock them and do aesthetic changes or functional changes. If we're like making an upper denture to lower crown and bridge, and we've got to follow that occlusion, but locked until I unlock it, and then I lock it again. And when the teeth are where they need to be, I hit a button, goes to the next spot, and the tissue goes from the margin. There's little margins on the teeth, and there's the margin where we did our border, and the tissue literally just fills in from top to bottom. I mean, just boom, it just goes. Now, we can sculpt it and do anything we would like to it. We can add papillas, take away papillas, textures, anything you'd like to do on that tissue. And then for try-ins, we always do printing just because it's quick and cheap, just to be honest. So these are bases. This is a couple of dentures. This is 2 sets of dentures, upper and lower. We printed those out of a denture base. Here are the teeth, same thing. Printed the upper and lowers. We're going to remove those supports. And then the teeth virtually just fit into the base. And then we, for lack of a better term, we bond them in with an uncured denture-based resin. We just take some of the denture-based resin that we printed with, put it into the sockets, put them in there, and then cure it. This is my favorite patient out of all the patients I've ever worked with on John. Cranham Bridge, diagnostics, occlusion, whatever. This is still my favorite. So this is a young man who obviously had a lot of problems with his teeth. No major occlusal problems, but John and the patient decided that they were going to go to implants on this case, so we're going to do immediate dentures. Now, there's a couple of ways you can do dentures. You can do them, there's two easy ways, and then there's a hard way. So if they have dentures in their mouth, and they're anywhere close. I mean, if they're horrible, you really can't do it. But let's say they're in the ballpark. I mean, they're in their 70%. So you reline with impression material, the upper and lower, and just get a really good tight fit to the tissue. And then you take that denture out of the mouth and you scan it in your hand, 360 degrees all over the place. Put that one down, grab the other one, scan it everywhere, inside and out. Put the two dentures together and scan it for a bite. I got all the data I need. Now, if you want to make the teeth longer, you want to change the midline, you could mark that on the teeth. If the teeth are too long, you can mark that on the teeth. If they need to be longer, you tell me. But at least we're a good 60 to 70% there already with just that data. Or an immediate denture where you're scanning in the mouth. So now this is the one that's actually easy to scan in the mouth. Scanning in the mouth for dentures, no matter what you see on YouTube, is not that easy. But scanning, if you've got teeth in the mouth, is a lot easier. So this is going to be a digital scan. Here's the teeth. So John is going to do an upper scan. He's going to do a lower scan, and then he's going to do a bite scan. We've already kind of decided that we like tooth number 8. So that, we've got one tooth in there that we can kind of use as a guide for our initial setup. And then I can look at anatomical landmarks for everything else. But it looks kind of like this. So the first thing we're going to do is extract all of those teeth. And it's really just one push of a button. You push a button, the teeth extract down to the gingival level. And then we're going to do the same thing. We're going to mark our borders. We're going to put our teeth in. Now, when we extract the teeth, the software automatically makes another file. So all the teeth that were just extracted, it makes another file to show us where those extracted teeth were. Even though it's not working, it's not in the way. John said, I kind of like that one tooth. Excuse me, number 9. So we kind of based it off that as just somewhere to start. And then I can use anatomical landmarks and just denture philosophies and denture techniques to figure out where the rest of the teeth go. So finer dental fabrication, we're going to do a try-in with printing on our final denture. We would go to mill. So we can either mill it out, look something like this, or we can print them. So this is the base printed and the teeth printed, and now we're adding the uncured denture base material into the sockets, and then we'll place the teeth. So this is how we make dentures today. Going to put the bonding, that resin in there for bonding. We're going to take the teeth, and then something we invented here is the denture holder together. And we're going to clip those two together to hold them together before we go to our final light cure. And that's going to bond everything together. So this is how we make dentures. So here's our patient. Extract teeth that day, immediate denture, and literally transform. I mean, this one just came out so cool. So John sent me these pictures, and I immediately texted back. I mean, because it was just such a change. I mean, it was just such a change. I said, he looks like Thor. I mean, to me, he looks like Thor. And he's got the most beautiful smile. And it just totally changed his face. So here's our patient. And again, using that one tooth, we did the entire tooth setup based on that one tooth. And again, gave him a little more aggressive tooth setup. So there is Thor for dentures. So dentures are actually a lot easier now. And we did a lot of research. Dr. Lennon Cooper and I, when he was head of research at University of Chicago, we did a pretty big research study to test everything because we wanted to see, is it different or better? So the one thing we found, and I found on every digital denture that we've ever done, and in talking with dentists, is the fit. So again, one of the interesting things when I was picked to kind of help out on this project, I started questioning everything. Why do we put teeth there? Why are teeth so flat? Why can't anterior teeth touch? I mean, it goes against everything we do in Cranham Bridge. Why can't we? Why can't we? Why can't we? Why can't we? They get so tired of me asking these questions that they just kind of gave up. And I finally got an answer. Yeah, and the answer that they gave me, I don't really even think they knew that they were giving me. But a lot of the things we do in dentures or we have done in the past is because dentures never fit in the first place. So not to say you won't get a hot spot or a place you have to adjust, but it's not like dentures of old, especially packed dentures, because they essentially didn't fit. These dentures sometimes fit so well on the final, if it's milled, you can't get them out of the mouth, especially on the upper. Obviously, lowers are a little bit different. And again, most of the dentures we do are in preparation to do this, which is all ceramic on implants. So 6% of our workflow is now printing. So everything you see here is printed. We've been printing all of our all on X for over 3 years. Really haven't had a lot of problems. Have we had catastrophic breakage? Yes, we have, of course. Anything we make has broken. Now, we don't get a lot of breakage because I would be out of business. So it's rare we get zirconia to break. And Emacs we only use on singles, so that's pretty easy. But zirconia bridges, zirconia all on X, and then our printed all on X as temporaries, we just don't get breakage. The problem we actually had more way back in the beginning, because we've been doing these things for over 12 years, is debonding of the titanium. And we really didn't know what we were doing back then, so it was our fault. But we actually have a great track record. We know what we're doing, as most labs do today, to be able to do these types of restorations very successfully. We do print all of our models, and we scan a lot of impressions to be able to not pour them out of stone. So if a physical impression comes in, we can scan those also. But even our complex implant cases with different types of scan flags coming out today, we get very, very accurate models for upper and lower, and this is an upper and lower implant case. So the next thing that we can do very easily, and this is really where we've evolved to in a laboratory, is surgical guides and surgical design. So the nice thing about the software is I can do a complex design just in my regular software where I've got a lot more control. I can get everything. I can change verticals. I can get the teeth. I can extract teeth. I can do virtually anything you think and get the teeth exactly where they need to be. I can print them out. I can let you look at them. I can let the patient look at them. We can do a matrix in the mouth, just to kind of try them in real quick. But then I can take that data and move it into my implant software. If it's something simpler, I've got my diagnostic design software within my implant software. So there's two ways to do it. But if I want total control it's easier to do it over here. Now, the cool thing is if we are using a denture to be able to do our diagnostics, I can use the denture, bring it into the software, and use that for design. One of the workflows I like the most on larger cases, if we can get the patient and the dentist to agree on, I would much rather extract teeth and put a denture in first and get everything exactly where it's supposed to be, where there's no questions about function, vertical, bite, incisal edge position, phonetics, or anything else, and then do a dual scan technique on those dentures and get the implants placed to support where we know exactly where the dentures go. But let's do a simple one here where we did a diagnostic design on a lower incisor. And this is actually many, many years old, but it's one of the first ones we did this technique on, because we've been doing this technique almost 10 years now. And that's a technique where we do immediate temps. So there's a lot of people writing articles about it today. We kind of figured it out a while back. So we are going to start with a diagnostic design. So we've got an intraoral scan. We're going to do a diagnostic design. And this is within the software. And then we're going to use that diagnostic design to set the implant. Now, even with implants, I could again talk for hours on where implants go. This was back really when angled screw channels were coming in. So we were still using the move it down, move it back, and place the implant so we can get the access hole behind the incisal edge. I don't do that much anymore. A lot of my screw access holes without angled channels would actually be coming out the incisal edge or the front of the tooth, but I can get a much nicer emergence profile doing that. But here we're gonna kind of keep it to the standard rules. So I've got my implant in there. That circle is how big my immediate implant hole should be to be able to set the implant. And you can see it here in blue. So we've got a guide made. We're going to bring the guide into our design software. The guide comes with this, I know where the hole is, so I know exactly where the hole is. So then I'm going to go into my provisional design, and I'm going to design an immediate temp, which is basically a pontic with a hole in it and two little wings that go on the adjacent teeth. It looks something like this. The hole is 1 millimeter in diameter bigger than the temporary cylinder, so there is a little play and a little area for you to glue it in on. But this can be done very, very quickly. So we bring all that data together. There's our temporary. We put little holes so you know it's seated. We've got the hole in the back. So the implant's going to go on. The temporary cylinder is going to go on. And this just slides right down over the top of it. And then you inject your cement of choice, which is composite, a bis GMA or a cement or whatever you'd like to do to attach the printed temp to the temporary cylinder. So we've got the model, we've got the temp, we've got the guide, everything matches perfectly together. Guide goes in the mouth, temporary implant is placed, temporary cylinder is placed on, and then the temporary just literally slides over the top of it. And then you cement the two together, unscrew it, take it out of the mouth, cut the two wings off, and add a little composite to the bottom to fill up the hole where it attaches to the temporary cylinder. So it looks something like this when we're all done, going from temporary to final crown, but very easy, very predictable. And here's our final crown. But predictable and easy. That's what we want. So, and again, so there's a lot of things we can do. We can make the guides. We do a lot of healing, custom healing guides now, tissue healing guides. And we do those out of titanium or out of PEEK or out of acrylic, but we can make those at the same time, and the temporary and the guide, if you want to heal the tincture or heal the temporary a little bit, but we can still make the temp for when you want to seat the temp in the future. but all those things could be made at the same time. But basically, what we can do in the software is get the teeth exactly where the teeth need to be. And that's the most important part. So this one, I actually did the diagnostic work within the software. So we've got the upper, we've got the lower. We can put the teeth exactly where they need to be to get the implants exactly where they need to be. We can look at the contours, we can look at the occlusion, we can look at the screw access hole, and we can look at the emergence profile to make sure the implants are deep enough to get proper emergence profile if the bone will allow. But there's so many questions that can be answered this way when we do the case. And then we go on to the final guide. So on this one, we've got the implant placed. We're going to take that data. So we're going to make the guide, but we're also going to take that same data because now we know where the implants are going to go, and we're going to make the healing caps that go for this case. So bringing the data over, we're just going to design over the tie bases that we use in our software. So instead of designing a crown, we're just going to design custom healing, and we're going to mill those out and then place them on the tie bases. So we would be sending the model with the tie bases and the healing caps glued on. We're going to do the guide at the same time. And if you can notice on that second picture, there's little slots that I've placed in the front because we didn't have a lot of vertical room. So when we don't have a lot of vertical room, and we know that from the doctor, the patient's not opening so much, we can make it so the drill bits go in horizontally from the side rather than vertically from the top when the patient can't open so much. But when we put everything together, everything lines up perfectly. We have the healing guides, and these were actually milled out of PEEK material, PEEK. They're just pink PEEK. So everything is lined up on the model. And this is something we've found that some dentists like, some dentists don't, but we've got some dentists who love them. And this is a little addition which allows the water spray from the drill to go directly into the osteotomy site rather than just kind of go from above. So these are called era guides. We basically drill a hole, glue them in, and you redirect your water supply into the era guide for better water and cooling. So looking something like that. And then we can get a little more complex with bone reduction, temporaries, stackable guides. But this is one which was very unique in that we started with a denture. So the guy had a denture. We redid the denture because if I do the denture, I have the data. If I use the denture that's in their mouth, I don't have the data. So this is one where the guy had been using a denture. The tissues were very firm. The bone was very solid. So we only using two CTs, just using CTs. And all this was done in one setting. So we got the CTs, we designed everything, sent it back to the doctor, and did not take a secondary impression. We did all this from the actual beginning. So we've got a lower, which has got a hybrid in it already. We've got the upper tissue. We've already done the guide based on the data from double scanning the denture, and you'll see that in a minute. So it places the implants in place in our data. So we're going to design the teeth. We know where the implants are. We know where the teeth need to be. We've got all this data. And then this, we'll start to design the teeth to the tie bases. So kind of like we did the healing cap, we're just going to do all this at once in the beginning and not go to a second digital impression. So here's all our data scanned in. So here's the original denture we made. And that was scanned back in. And we were then able to bring all this data back in, make all our models, make all our mountings, put everything together. So we started with a denture and double scan that denture, use that denture to, because we like where the teeth are, so we're going to use that for tooth positioning, but we're also going to extract from that CT implant placements because we've still done the guide at this time also. So we made the guide and the models and the temporaries all at the same time. So here's our guide. Very solid on tissue, but we did use retention pins just to make sure it stays in place. This is one of our CCDD doctors, Dr. Kevin Cross. So we've got our models, we've got our guide, we've got our temporaries, all made from the CT. So there's no intraoral scans on this case. So day of surgery, and again, this is very firm tissue, very dense bone everywhere. No immediate extraction sites. Guide was placed in, pins replaced, implants are placed, temporary is placed. And we're checking the bite, checking the aesthetics, making sure everything's good. And it actually went into place very, very nicely. We do that in certain circumstances that we feel comfortable in. Sometimes we do. It really depends on how dense the bone is. Immediate extraction sites, it does not work well because those extraction sites can deflect the angles of the implants as they're being drilled in, which can cause non-accuracy. But we were able to do some very, very cool things. So, and again, this is what John and I wanted to go over today. There's all kinds of really, really cool things we can do digitally, not just differently, but better. Better, faster, more efficient, more predictable. It allows John and I, or you and your laboratory, to communicate like you've never communicated before, while still keeping to those protocols that we learned from Pete so many years ago. Again, John and I don't do anything different. We just do it in a digital format, a lot more predictable today. So again, I'd like to thank everybody for spending time with us today, letting me show you a little of what we can do as a dentist laboratory team in digital today. So everybody, have a wonderful rest of your day. Thank you so much.